Today's featured presentation is entitled Protecting Kids' Teeth, Exams, Sealants, and Varnishes, presented by Dr. Ida Rose Mize. Dr. Ida Rose Mize is a graduate of the University of Iowa and Howard University, a certified pediatric dentistry. She's a diplomat of the American Board of Pediatric Dentistry and currently is a co-owner of the Children's Dental Group in the metropolitan area of Atlanta. Dr. Rose Mize is a wife and mother of 2 children. Accreditation for this event, an application for CME credits has been filed with the American Academy of Family Physicians and the Academy of General Dentistry, and it has been approved for 1 hour of CME and CDE credits. As for the question and answer section, which I know you guys are all eagerly anticipating, today's presentation will be divided into 3 sections with a brief intermission for questions from the audience at the end of each section. There will be an extended question and answer session at the end of the presentation. However, questions and comments can be submitted to the presenter throughout the presentation, so don't be shy if something comes to mind. Please feel free to sprinkle questions throughout the presentation, and we'll answer them as it comes up. To submit your questions to the presenter, just please type your questions in a box that you'll see in the lower left-hand corner of your screen, and hit the submit button. Now, without any further ado, I welcome you, Dr. Ida Rose Mize.
Hello, everyone, and thank you for joining us this evening. I first want to start out with a disclosure statement. In compliance with the American Academy of Family Physicians guidelines, I do declare that I don't have any financial or other relationships with the manufacturers of any commercial services discussed in this educational activity. So, as he mentioned, the title is Protecting Kids' Teeth, Exams, Sealants, and Varnishes. I am a pediatric dentist. I have been doing this for since 2002. I graduated from my residency in 2002, and I've seen a lot. I've learned a lot, and the more I do it, the more I actually like it. You know, some days are better than others. There are some children who scream a lot, but to me, I love it all every day. And you'll be surprised. People ask me all the time, you know, why? Why did you choose pediatric dentistry? What is it about children? Aren't they kicking and screaming? And yes, they are, and you know, we have ways that we manage them. From what I understand, I'm speaking to a variety of people this evening, differences in healthcare providers, mainly dentists, but also some nurses or pediatricians or other healthcare providers. So I'm going to try to give a little bit to everyone. So for those things that may seem kind of basic to the dentist, just kind of bear with me. And for those things that may seem a little bit over your head, like what is the mesial of a tooth, for someone that may not be a dentist, again, just kind of bear with me. So, first we're going to start out with an overview. What we're going to talk about this evening is what is a pediatric dentist? You know, why do we have pediatric dentistry as a specialty? Why do we even treat baby teeth? The age-old question, if I had to list the top 5 questions in my office, you get a parent that says, oh, it's the baby tooth, right? It's going to fall out anyway. So you know, why is it important to even treat baby teeth? Caries, what are caries? And the whole disease process and what causes it, as well as ECC, which is known as early childhood caries. And after talking about the disease process in the beginning of the presentation, we'll shift on over to prevention, which is actually a really, really key component in dentistry. We'll talk about exams and anticipatory guidance in your exams, as well as something called CAT, or Caries Assessment Risk Testing. Sealants and fluoride, and how they could be very good aids in prevention. And then in the end, we'll kind of wrap up with some common things that are seen in pediatric dentistry. So, pediatric dentistry. The thing I like about pediatric dentistry is that it's the only specialty in dentistry where it's really just age group specific. It's not based upon a specific procedure. For instance, an orthodontist that takes care of braces, or an endodontist that may do root canals. Pediatric dentistry is almost like a general dentist for children. So you have a little bit of this and that. But we take care of children in a special way. You have to like dealing with children because children come with their anxieties and their fears, and you have to know how to talk to them. We can't come and tell them, oh, we're going to give you a shot. We have our special ways of dealing with children. We deal with children or even with some adults with special care needs, some that may have cerebral palsy or different types of medical issues. We have been trained to deal with those types of individuals. Also hospital cases. Sometimes you have children that have rampant decay, decay in possibly all 4 quadrants of the mouth, which I will show you a slide with something like that. And that may be a child that you may need to treat in a hospital setting. Or some children that have special health care needs may need to be treated in a hospital setting. So that is under the umbrella of pediatric dentistry. And also sedation. If the child may not necessarily need to go to the hospital, perhaps we may need to treat them for sedation because they may be still just a little bit anxious with dealing with getting the dental treatment done in the chair. So there are different sedation modalities that we use as well. Uh-oh, sorry. Okay, so why do we even treat baby teeth? Well, if I had $1 for every time a parent came in and I told the parent the child has a cavity and the tooth is going to need a filling or even something more in detail than a filling like a pulpotomy or a crown, you don't know how many times they look at me like, what? The tooth is going to fall out anyway, right? So I have to go in and explain that baby teeth are really important for several reasons. Baby teeth are really a gateway to permanent teeth. They serve as space maintainers. So baby teeth are holding the space for the permanent teeth when they're ready to come in. If you get an infection in a baby tooth, it could actually start affecting the permanent tooth. Baby teeth can cause pain. And if you have a child that's in pain, the child can start, that may not want to eat. The child may start missing school. There could be a lot of different problems. So there are really, really important reasons as to why we treat baby teeth. So here's a slide showing, if you look here with my pointer, this is a depiction of where the permanent teeth are in proximity to the baby teeth. So if you look here, you can see here are the primary molars, and here are the premolars that are in the bone that are in between the roots of those primary molars. So if, let's say for instance, you have this tooth that gets a carious lesion on it, and then it is left untreated, then the tooth can eventually turn into an infection, and it could affect the permanent tooth here. And then you can go into problems with space maintenance because this tooth and the two teeth on the adjacent side may try to start closing in and block that permanent tooth from coming in. So baby teeth do serve as important space maintainers for permanent teeth. I know this is probably a dental school 101. When we first get to school, this is one of the first things we learned about after you go to your waxing class and learn how to wax up those teeth. You go to cariology and they teach you about how caries is actually an infectious disease process. The CDC states that more than 40% of children have caries by the time they get to kindergarten. That's amazing to me. 40%, that's almost half of children that have caries by the time they're 5. It's the most common chronic disease in children, actually more so than asthma. And if you think about all the children you know or have seen or have heard of that have asthma, you'll know that that's a lot, even more so than eczema. That's a lot of children. So how do you get caries? I call this my little recipe for caries. So take a microflora, which would be, let's say, the bacteria. So you have bacteria. The bacteria releases acid, okay? Then the acid starts coupling with the diet. Sugars, carbohydrates, which you know is going to start breaking down into sugars. Then add the host and a little bit of time. They start spending more time together. And then, boom, you get caries. So the bacteria, coupled with the diet, on top of the fact that you may have poor oral hygiene, the plaque that's in the mouth, those factors together will give you caries. So, in Sweden, Gustafsson decided, along with some friends, he was going to do a study on how caries is linked with the diet. Because diet is very, very important with respect to caries. And a lot of people don't realize that. They think that it's just about not brushing the teeth. But really, diet has a lot to do with caries. So Gustafsson found that a diet that is high in fat and low in carbohydrates and sugars gave you less caries. And that refined sugar versus the sugar found in like caramel, refined sugar is actually better. So I guess if you have to eat something with sugar, it's better to go with a type of refined sugar or one that won't stick on the teeth, like a caramel or gummy bears or fruit roll-ups, things like that. Because caries was increased when you find it in sugar in a form that is more easily retained on the tooth. Again, like I said, like a gummy bears or something like that. Especially if you're snacking and giving in between meals. It's very important. The frequency is very important. Weiss and Treehart, they also did a study that pretty much backed up what Gustafsson said, especially about consuming sugar in between meals. Let's see. So, along with caries, increased sugar has been found linked to obesity. Back in the past 25 years, I was shocked to see that childhood obesity has quadrupled. That's high, that's a lot. Has quadrupled in children from ages 6 to 11 and actually doubled in children from ages 12 to 19 because of diet. You know, I mean, it's the foods that they're eating now. The USDA and the DHHS recommends that diets high in vegetables, fruits, whole grains, and low in fats and cholesterols are actually what's best. But I'm sure that we all know that. But sometimes it's good to have a reminder, and we do need to educate the population about that. And we do need to use sugars and salt in moderation. Now, surprisingly, in my research, I found that there was not a correlation between obesity and caries, even though there's a link between increased sugar linked to obesity, but not a direct correlation with obesity and caries. And I thought about that, and I found that that's because, as mentioned before, it's the frequency. It's not so much the sugar, it's the frequency. So the more frequently you eat foods high in sugar, especially the sugars that stick more on the teeth, the higher the incidence of being able to get caries. Because more frequency means that you're actually lowering the pH of the acid. And remember my little recipe for caries, you're lowering the pH of the acid released from the bacteria. And a low bacterial count with a lot of sugar exposure can be just as cariogenic as a high bacterial count with less sugar exposure. Studies have shown that if a child is in the 85th percentile of the BMI, there's an increased chance of diabetes in that child in the future. And those that are in that 85th percentile, about 75% of those have a high cholesterol. Those in the 95th percent of BMI, 100% of those had high cholesterol. So really, diet has found to have a large role, not only in caries, but also in linking to obesity in children. So recognizing the importance of this, the American Academy of Pediatric Dentistry came up with its own recommendations. And they stated how we as practitioners need to be more diligent about educating the public about the frequent consumption of these carbohydrates and how it can link to caries. And we also need to educate them about the other health risks associated with it, like I said, with the diabetes or the increased cholesterol when you consume carbohydrates, fats, and sugars and foods that are high in sodium. We also need to, AAPD also encourages providers to give a dietary and nutritional counseling. You know, the little pyramid where you may have to have them write on the sheet what they ate per day for about a week, just to kind of monitor what the patient may be eating to make sure that they have a good dietary habit. And the American Academy of Pediatrics, as well as Pediatric Dentistry, recommends that children from ages 1 to 6 have no more than 4 to 6 ounces of juice per day from a cup, not even a sippy cup, as part of a meal or snack. The in-between is what's really more dangerous, when you're snacking and drinking a lot of juice in between, as opposed to doing it with a meal or a snack. Yes. Okay. Breast milk, formula, and caries. I don't think anyone would argue that breast milk is definitely superior in nutrition. With breast milk, the baby is feeding from the mom, getting the mom's antibodies and nutrition from the mom. So definitely it is superior. And breast milk itself is actually not cariogenic. And you know, when I read this, I was a little bit surprised, because I was thinking, well, you know, all these years you hear about the nursing caries or baby bottle tooth decay, where the child was breastfeeding for so long, or had the bottle at night, which could have had formula or breast milk in it, and how the child developed a lot of caries. So I was wondering why, when I read that it by itself is not cariogenic, then it started to make a little bit more sense. It states that it's not necessarily the breast milk itself that causes caries, but going back to the little recipe for caries, when you start coupling breast milk with other factors, food and juices, even in some babies at this point, that's when you start getting a higher increase in caries. So the AAPD recommends to discontinue at-will feedings when the first tooth erupts. The first tooth erupts generally about 6 months old. So it kind of made sense. About 6 months old is when children usually start eating foods as well. And so if you couple that breast milk with the child starting to eat foods, then this is why we want to discontinue the at-will feedings when the child's first tooth erupts. Dr. Pamela Erickson did a study on formulas and found that formulas actually can be very cariogenic. And she said that formulas can dissolve enamel, and most reduce the pH significantly, which makes the mouth more acidic, and then of course makes the mouth more prone to decay. And she also found that some cause dental caries as early as weeks with certain formulas. And some also supported significant bacterial growth. So definitely formula seem to be more cariogenic than breastfeeding, but then again, we do want to make sure that we discontinue the at-will feedings when the first tooth erupts. So we generally recommend discontinuing bottle or breastfeeding by about 12 months. And moving on to the sippy cup. Now, sippy cup is good, but sometimes sippy cup can be a little dangerous as well. Sippy cup allows you to just take your juice or your drink everywhere with you when you go, kind of like the bottle. At this point, the children generally have a lot more teeth. And if you're, again, it's the frequency. If you're drinking juice over the course of the day, and you're taking the sippy cup everywhere you go, this is where you have the potential to get a lot of caries. So although we're weaning off the bottle, at about 12 months. When we move on to the sippy cup, we also want to make sure that we're limiting using the sippy cup at mealtime. I know children, I have my own young ones, and I know they need to drink a lot of juice or water or milk throughout the day, but try to wipe those teeth off, because the more frequently you're giving a substance, that's the higher chance that you're also introducing caries. And we recommend weaning off the sippy cup by about 18 months of age. Okay, so let's start talking about caries and early caries. And this is how caries starts out. The little arrow pointing in the first slide. This is what's called a white spot lesion. And that's the early sign of caries. A white spot lesion, or something called decalcification, or the demineralization of a tooth. And so it'll start out with this chalky white area, generally around the gum line of the tooth, and then eventually it could go and start becoming into little pitted areas like you see on the slide at the bottom, where the tooth actually starts becoming cavitated. As it progresses, if it's untreated, then you can see the progression that I have here in the slides, where you start losing tooth structure, the teeth start breaking off, then you start getting little nubs in the mouth, and you'll be surprised. You know, I've actually seen this, and it's really kind of sad that you see this happening in children. But this would be an example of a child who, a lot of times, they were on the bottle all night long, or let's say this child could be about 3 years old. First time coming to the dentist, mom had him on the bottle an extended amount of time, slept with the bottle, then after the bottle started using the sippy cup, went to bed with the cup, and just never brought the child in. And so at this point, the child may not even be in pain. You'll see them and you'll think, oh my God, you know, but may not even be in pain. It may be one tooth in the back that's causing pain, but all of the other ones where they're nubs, doesn't even feel it. And at this point, this would be an example of a child that may need to go to the hospital to be treated. So, what is early childhood caries? Early childhood caries is, according to definition in our pediatric guidelines, is the presence of one or more decayed teeth, missing or filled teeth in a primary tooth of a child 71 months or younger. Severe would be if you had a child younger than 3 with a smooth surface caries. So smooth surface caries are those found on like the fronts of the teeth. So by the time you get caries on the smooth surfaces, we figure that it's pretty serious at that point. ECC is an infectious process. It actually can be transferred. So basically, when a baby is born, the mouth is pretty much sterile. Doesn't have the decay-causing bacteria in the mouth yet, which is Streptococcus mutans. And this decay-causing bacteria is acquired throughout time. So vertical transmission usually occurs generally from the caregiver to the child. And a lot of times it's from the mother. You know, nothing against dads, but a lot of times the mothers are the primary caregivers. And so a lot of times the mothers are the ones that are transmitting the caries. So patients or parents will ask me a lot, oh, you know, he's got teeth like his dad, or she's got teeth like her dad, and it's genetic. Caries aren't really genetic, but they can be transferred, and that's what I try to explain to my parents. There's a difference. So it's not passed through the genes, but once the child is born, and once the child starts getting teeth at about 6 months of age, and you get that inoculation process, then you can start transferring the caries by kissing the child in the mouth. If the mom or the caregiver or whomever is kissing the child and that parent has caries in the mouth, that's one way to transfer. Also by sharing foods. You know, oh, I'll take a little bit and then mommy's gonna let you have some. That's how you can also share bacteria and the child can get caries. And the utensils. Sharing utensils between siblings. So if the sibling has caries in the mouth, you don't want the siblings to start sharing foods or utensils with the younger child, because that's another way of vertical transmission. Another thought is, if the mom has caries during the prenatal period, one good thing could be to reduce the mom's caries rate, knowing that once the child is born, this vertical transmission could occur. So the mom, it's really important for mom while she's pregnant to make sure that she stays up on her dental visits, so that once her child is born, she will not be infecting the child with caries. Okay, so for those who are not dentists, let me just take a moment and kind of show you the anatomy of a tooth before we get into the caries process. So the outer level, or the white portion, is called the enamel. That's the very strong outer white portion. Directly underneath is called the dentin. The dentin, under the dentin is the pulp, or the nerve chamber. This is where the tooth gets its sensation and goes down into the bone. So this would be a progression of caries. Say it starts off here, really, really small. Child comes in, I'll give you a scenario. Child comes in, 5 years old. You tell mom, little Johnny has a cavity on this baby tooth. Of course, she's going to say, oh, it's just a baby tooth. You know, what? We don't need to fix that, or what's going to happen, blah, blah, blah. You go into, you explain, Mom, it's important to fix this baby tooth because it could spread, it could get to the nerve. Okay, Mom decides, well, I don't want to get it taken care of. 6 months later, she comes back. We take another x-ray. Mom, little Johnny still has that cavity. As a matter of fact, it's getting bigger. Yeah, he has said his tooth was hurting a little bit. Yeah, 6 months ago, we could have done a filling on it because it was restricted to the enamel, or the outer surface. At this point, little Johnny's cavity is getting pretty big. It's getting really close to the nerve. So we're going to have to treat the nerve. And by treating the nerve, we'd have to do something called a pulpotomy, where we go in, take out the top part of the nerve, put some special medication inside, and then protect the tooth with a silver cap. Well, at this point, she thinks I'm crazy because I'm talking about doing a root canal on her child, and and it's much more expensive, and well, I can't really do that right now. So a month later, now it has really progressed, and it's gone into an infection. And this is what you see on the last tooth, shows the infection that has now developed in the bone. And now this is going to become systemic. And again, going back to the slide that, one of the first slides that we talked about, the permanent tooth is developing right in between the roots. So if at this point it's still not treated, then the permanent tooth can now be affected. Not to mention how it could start affecting the fascial planes. The child can start getting cellulitis, an infection, and could potentially end up in the hospital. And I have had some patients that have had dental infections that have brought them to the hospital. Unfortunately, there have even been children who have died from dental infections. And, that's really, really unfortunate for something that is preventable. These children have died from that. So this would be a picture of an abscess. So after that decay has grown and has gotten to the point where it was not treated, and the infection has gone into the bone and has started swelling, you would see it manifest in this manner. And so at this point, these teeth would require extraction. But again, now we're talking about space maintenance issues, because once you extract that baby tooth, the baby tooth was there as a space maintenance for the permanent tooth. So now we have to look at putting in things like space maintainers so that the other teeth on either side don't close and that permanent tooth can come in as it should. This would be another example of an abscess. Now, when you get an abscess on a second primary molar and the permanent molar has yet to erupt, then we're getting into a little bit more of a tricky situation, because when that permanent molar is ready to erupt in the mouth, with that baby molar gone, that permanent molar can drift into that space. So the space maintainer becomes a little bit more difficult at this point to try to do. It's called a distal chute, but that's why it's important to really try to maintain the second primary molar. Now, for other healthcare providers that may be listening, like nurses or pediatricians, you know, when the child comes into the office, you can look at first glance, this child looks great. You know, oh, look what beautiful teeth, nice, shiny, doesn't look like he has any cavities, and you open the mouth and it's like, wow, what happened? So the importance is, you know, when you're going back looking at the tonsils, don't forget to look at the teeth, because this is what the child could actually look like inside of the mouth. And we want to make sure that this child gets referred to a pediatric dentist and definitely gets attention. Okay, so I'm going to stop and break for questions. That's the first part. Now we're going to move into prevention after this, and I just want to stop and break for any questions. Okay, great. I guess everyone's doing good. Okay, well, what's really important is prevention. You know, I showed you all of the really yucky stuff, but what the good news is, it can pretty much be prevented, and it's really by early detection, intervention, and routine dental care. According to the American Academy of Pediatric Dentistry, we recommend that the first dental visit is by age 1. Now, I actually had a parent that told me maybe about 6 or 8 months ago. She has an older daughter that I've been seeing for years, and I never knew she had a younger daughter. So she tells me at this one visit with her older daughter, oh, I need to bring my younger child in. And I said, oh, okay. She said, yeah, it should be about time. She's 3 years old. And I said, oh, definitely. We actually start seeing them at 1. She actually told me 1? Wow, somebody didn't have anything better to do. And I was like, oh, okay. Well, actually, they did. And I had to try to explain to her why we start seeing children at age 1. Needless to say, when she did bring the child in, the child had a mouthful of cavities that I had to end up fixing. That was sad, but she gets the point now. We start seeing children at age 1 to establish a dental home. A dental home is a place where we can deliver comprehensive dental care over time and get to know, you know, set up a family environment instead of a clinic environment where the child is just kind of running in and out for emergency care. So we want to be able to follow this child, make sure that they're getting everything they need, and they understand dentistry and why it's important to have good oral hygiene. So I mentioned this before, how bacterial colonization starts at 6 months and how it can be transferred mainly from mother to child, and you don't want to share any foods. This is why, again, age 1. Sometimes I've seen patients as early as 6 months for just a routine visit. And if you know you have a child that may be at a greater risk of getting caries, you may want to consider bringing that child in at earlier than a year. And we'll go over that. That plays a part in the caries assessment risk. So this is an example of what we do at the infant oral exam. This is actually my partner, Dr. Redwine, here in my office, and this is called the knee-to-knee exam. And what we do is we bring the child in, and I tell the parents an infant oral exam is more of a parent-doctor session. We're not getting in there trying to clean the teeth. Hopefully we won't see cavities, but you'll be surprised. There are many, many times where I have found cavities on an infant. But you do the knee-to-knee exam, and it's basically a time when you're just going to share with the parent what we are looking for, what we expect to see in the child, the growth and development, and what the habits are at this point, and what they should be doing or should not be doing. So with infant oral exams, again, it's the parent-doctor session where we're doing a lot of educating. We're going to talk about anticipatory guidance, which is basically going through the dental development. We're going to check the fluoride status and talk about if the child is on fluoride and how much fluoride the child should be getting at this point, and also discussing any habits and the harmful effects that habits may have. So what is anticipatory guidance? I saw this definition, and again, this is taken straight from our pediatric handbook guidelines, and I love this definition. It said providing practical, age-appropriate information about children's health to prepare for certain milestones. Basically, just talking to a parent at a certain age about what should be going on with the child and what they should expect in the future for the child in dentistry. And it's discussed at the exam visits. You know, usually at a comprehensive exam is when you really go into a lot more things as opposed to a recall exam. But it's definitely important that you talk about anticipatory guidance, especially at certain milestones. Mainly it's done with the parent, but you know, if you have a child that's, say, 12 years old, definitely teenagers, then that's something that you can discuss with the child, the anticipatory guidance, instead of with the parent. So I'm just going to go kind of step by step as to what the anticipatory guidance should be at the different stages. So let's go back to the infant oral exam. So 6 months to 12 months, doing an infant oral exam with anticipatory guidance. It's an exam to assess the oral growth and development, pathology, and or injuries. So you want to look in the mouth, make sure that all the teeth are developing properly. And you know, teeth vary how they come in. I'll have some parents come in with a child that's 18-month-old. In fact, I had one yesterday. The child may have been 15 or 16 months old, and she only had the 2 little baby teeth at the bottom. And sometimes they get really concerned, like, oh, why doesn't my child have any teeth, especially when they start looking at other children that have a mouthful. And I explained to them it really, really varies the way baby teeth come in. What I'm most concerned about is by the time they're 3, that's when most of all the baby teeth are in. So in between that time, it really, really varies how they come in. We go over oral hygiene. Some of them don't know that you start brushing the teeth at this point. You know, you tell them, are you brushing the teeth? Oh, I didn't know you had to brush them. Yes, go ahead, start brushing the teeth. You brush your teeth, you know, go ahead and start brushing the baby's teeth. You may not have to get in there on a 6-month-old with a toothbrush, but there's a rag. You can use a rag to start brushing the teeth. Or the little over-the-counter toothpaste sometimes have the thimble inside of them. You can use the thimble to brush the teeth. You want to talk about the health status. You know, is this a child that was premature? If it's a child that was premature, there are different things that can come into play with how the teeth may develop. The child may have enamel hypoplasia when the permanent teeth come in. The baby teeth could have certain things. The teeth could be delayed in development if the child was premature. So you go over the health status. And not only of the child, but also of the caregiver, because again, if the caregiver has a lot of dental caries, we want to be careful in transferring that disease process. So definitely talk about that as well. Sometimes you see staining in the children, and if you see staining, you can talk about or remove the stains. Generally, it comes off fairly easily with the prophy paste, but that's something that you may have to do at that first dental visit. Also, fluoride. You want to assess the fluoride status and talk to the parent about formula and how formula actually has been found to have fluoride in it, as well as the toothpaste. And we'll get into that a little bit more in a minute. Okay, continuing along with the 6 to 12 months, the feeding practices. Is the child still on the bottle? If the child is 12 months, we want to talk to them about, well, it's about time we go ahead and get them off the bottle, or breastfeeding. Injury with regard to trauma. Some of them are just starting to walk. Some of them are still crawling. Crawling babies can get into a lot of things. They can bite on the the cords, and you can get the electrical burns. So be sure to talk about those types of things. Habits, pacifiers, the fingers. Habits can cause a lot of different changes in the mouth, like open bite or cross bites. Also, you may have to do treatment. If you find caries, you may have to do some sort of treatment or come up with some sort of treatment plan of how you're going to monitor this child. Caries assessment risk. We're going to talk about that. You determine a caries assessment risk at that first visit, and you're going to discuss whether a 6-month recall or a 12-month recall or maybe even a 3-month recall is adequate. 12 to 24 months. A lot like the 6 to 12 months, but now we just kind of make sure that the feeding practices have been updated. So at 12 months, we talked to them about getting off the bottle if they weren't. But 18, 24 months, we need to make sure they're pretty much off of that, and also weaning off the sippy cup. At this point, we want to review the fluoride status. Fluoride, according to our academy, should be started when the first tooth erupts with a smear amount, less than a pea-sized amount. So we want to discuss that. And possibly provide topical fluoride treatments. 2 to 6 years. You may have to start scaling teeth. This is when, especially closer to the 6-year-old range, we may be starting to get into the mixed dentition. And so you may have children that are going ahead, they're brushing their own teeth now, maybe developing calculus buildup, may have to scale those teeth. Sealants, talk about the importance of sealants. Some of these children are now starting to play sports, 5- and 6-year-olds. So we want to talk about mouth guards to avoid the sports injuries. We want to look at malocclusion as this mixed dentition is coming in, where they're getting their permanent teeth in with the baby teeth. Look at how those permanent teeth are coming in, if they're crowded, if they're too much overjet. And we also want to assess speech and language development to see if the child may have some sort of ankylosing and may need to be referred to a speech pathologist. The greatest incident of trauma actually occurs when the child is 2 to 3 years old. And generally that's because that's when they are moving the most. So back to that 2 to 6-year-old range, we also want to make sure we discuss trauma and using that the mouth guard. 6 to 12-year-old, we want to repeat what may be applicable for the 2 to 6-year-old range. Now, these children are in school. They're learning from their friends all kinds of bad habits sometimes. So they could be starting to use tobacco. We may need to talk to them about the piercings in the mouth and the dangers of that. And this is about the time we need to refer to the orthodontist if you see that that's necessary. 12 years and older, this is when they're getting into the late adolescence. We want to see about getting them into braces, consider third molar extractions. They may need to go and see an oral surgeon. And at this point, especially in my office, we generally stop treating patients around 15, 16 years old. So we may need to look at transitioning them over to a general practitioner. So what is CAT? CAT is a very important part in pediatric dentistry. And the definition, according to the manual, is the determination of the likelihood of the incidence of caries during certain periods of time, or the likelihood that there will be a change in the size or activity of lesions. Basically, that just means what is going on with this child that we think the child may develop caries in the future. What's the likelihood that, according to the surroundings and what is going on with the different factors of this child, that the child may develop caries? So the goal is to prevent the disease by identifying and minimizing the causative factors and optimizing the preventive factors. If you have the ability to detect caries at an earlier stage, you can help prevent the cavitation. Caries assessment risk anticipates the caries progression. It tailors preventative care to each of individual's needs. And that's what I like about it. You can have one child, 2 different children that come in. One can have, they both can have the same type of decay, but you would tailor it differently based upon their caries assessment risk. And this is something that you may need to update and change over time as the child's habits change, as their physical condition may change, and the microflora in the mouth. Okay, I don't know if you can see this that well, but this is a little chart that we have in our guidelines, and it breaks down caries assessment into low, moderate, and high risk. And there are different factors that will determine if a patient will be in low, moderate, or high risk. Clinical conditions. Let's say, for instance, with clinical conditions, if the child does not have any decayed teeth in the past 24 months, that would be someone that is in a low risk, versus a child that has had decayed teeth in the past 12 months. That would be one that's more in a high risk. But you also have to take into account other factors. So along with the clinical conditions, we look at environmental. So is the child getting fluoride? If the child is getting fluoride versus one that may not be getting fluoride, that would determine if they're in a low versus a high risk. And the moderate would fall somewhere in between. So let's say this is a child age 0 to 6. Okay, and we'll just do an example. Let's say you have a child that is not exposed to fluoride and is still on the bottle and is in a lower socioeconomic status, and the mom also has caries. This would be one that would be considered a high risk, and you would treat that child, the treatment plan on that child would be different than, say, another child where first dental visit was age 1, there is fluoride exposure, mom does not have any caries, higher socioeconomic status. So even though those children may have the same amount of, the same one cavity at this certain visit, the treatment plan could be totally different on that child. The child at a higher caries risk, we may look at being a little bit more aggressive. The child at a lower caries risk, we would look at just doing maybe a filling. A child at greater than 6 years old, basically the chart is pretty much broken down the same way, and you can kind of review through this, but one at a higher risk, we would be more aggressive than one at a lower risk with the same factors. So this would be an example of the management of a child with a high, moderate, or low risk. So let's just go to, say, the 3 to 5 year old range. So one that may be at low risk, say the child comes in and they have a very small cavity on the tooth, and the child has gotten sealants already. That may be one that we may opt to watch, versus a child that comes in, the parent is not very engaged, the parent has potential for cavities, the child does not come to their recalls, then that's something that instead of just watching that cavity, we're going to be more diligent about fixing it. Oral hygiene is important. So brushing, we want to make sure that they are brushing at least twice a day, as well as making sure to brush the tongue. Flossing also is really, really important. Flossing minimizes decay in between the teeth, and it also keeps the gums healthy. So this would show a child with gingivitis that needs to floss. So the gums are kept healthy generally with the flossing. So back to our picture of the tooth, this would be the supporting tissue. So when you are not flossing, or when the gums become inflamed, the supporting tissue, or the gingiva and the bone, is destroyed. Okay, sealants. Sealants are, I think it's safe to say that most dentists would agree that sealants are one of the best preventative measures when they're placed properly. But I do want to stress when they're placed properly. Technically, sealants can be a very, very simple procedure that can really be done by the hygienist or even the expanded duty dental assistant. But sometimes it can be a little difficult, especially if they're not put on correctly. Sealants help prevent food and bacteria in the grooves. They may last up to 5 years, and they reduce the probability of caries, according to Griffin, by 70%. Simonson, he did a study on sealants, and actually he is the longest running person to do a study on sealants, a 15-year follow-up, and he didn't use primer. He did sealants and found that after 5 years, 82% of his sealants were still intact, and after 15 years, 27%. I thought that was amazing that the sealants were still intact. And sealants placed over minimal enamel caries have shown to actually be effective at inhibiting the lesion progression. A study was done at the University of Ohio where they used two different groups. They had a group of sealed teeth with incipient lesions and sealed teeth with no incipient lesions. And after 5 years, they actually found that 8% of the teeth that had been sealed in the non-incipient group had caries, and 11% did not have caries. But of the group with incipient caries, 12% of those had become carious, and 50% of the ones that had not been sealed had become carious. So there definitely was an indication there that it's okay sometimes to go ahead and seal over incipient caries. From 1999 to 2002, the prevalence of using sealants increased from 19.6 to 32.2%. But in 2010, surprisingly, we were still well below our national average objective of 50%. It was found by the CDC that white children from higher incomes were much more likely to get dental visits and sealants over minority children. So this is why they came up with this school-based sealant program. So with the school-based sealant program, it was geared toward schools with low-income families. And with these programs, all you need is a visual assessment of the surface cavitation. So you don't need to go in there with the mouth mirror and explorer. You can clean with a toothbrush or handpiece prophy, and the four-handed technique is preferred. And you don't have to use bonding agent. Now, to me, there are some pros and cons. This is not in the literature. This is just my personal opinion. Definitely, it's been shown that, and I've shown that sealants can be very beneficial. And for those that don't have access to care, this is great, because this is a way that they can be seen, because, of course, they have less access to getting to the dentist. But sometimes these people can use it as a crutch. I had a patient that came in the other day. I hadn't seen her in 3 years. Mom said she had been on the dental van. And that's okay, but the child had a mouthful of cavities, and if they're using it as a crutch for those children who can actually come to the dentist, they're not getting that comprehensive dental care. Also, if you have incipient caries that are actually growing, and they may look incipient, and you seal on top of them, they may not actually be that incipient, and you're locking those caries in. Here in Georgia, we actually have school entrance exams, and this is great, where the child has to come in and they have to get a dental exam, medical exam, and eye exam before entering the school. And this is important because researchers found that children have missed a lot of days due to dental problems. So I'm glad that we actually have these entrance exams. Fluoride. Fluoride is found just about everywhere. And it's found in fresh water, fish, vegetables. Fluoride by nature is a halogen. It's absorbed in the GI tract and excreted by the kidneys. And it's secreted into the saliva and enters the enamel and enhances the calcification by decreasing the caries susceptibility. It's very economical, even more economical than the sealants. So it would be the most economical and effective way to prevent caries. It arrests the progression of caries by remineralizing the enamel. Remember, the bacteria demineralizes, so the fluoride serves as a remineralizing agent. And it makes the teeth more resistant to acid attack after the eruption into the mouth. So these are different types of fluorides. There are a lot of different types. The 1.23 APF, that's actually what we use in our office. That's what most people use. This is the Smart Rinse. Smart Rinse is a daily rinse that I recommend to children when I see they have caries, especially interproximal. They rinse with that every night. And here is actually a chewing gum called Flouride. And so if you see that a child may be in an area where they don't have access to a lot of fluoride, and you think that they may need more fluoride, Smart Rinse or the Flouride may be something that you might want to consider. There's also Flouride Varnish. Now, Flouride Varnish is a very higher concentration of fluoride. With Flouride Varnish, the advantage is you do get less vomiting, and it is released at a slower rate than the toothpaste, so you don't have to reapply it as much. You reapply it only every 3 to 4 months. It's fairly simple. You wipe the teeth with gauze, you paint the varnish on, and then you tell the parent not to brush till the next day. So this would be an example of where you might want to use Flouride Varnish. This top picture shows the decalcification. That would be a prime example of where you might want to use Flouride Varnish. The ones at the bottom, we're getting more into where you may want to do treatment. This is all you need. This is with the varnish, how it comes, and basically you just need the gauze and the little varnish pack. Oops. So this is showing I'm wiping the child's teeth, and then you just kind of paint the varnish on, and you do tell the parent don't brush the teeth for the rest of the day. And also you need to make sure some of the varnishes come in a yellowish color, so make sure they know that in advance, just to make sure the child's not taking any pictures or anything. Now, sometimes too much of a good thing can be harmful, and when you have too much fluoride, you get fluorosis. And fluorosis basically is when the tooth is hypomineralized, the enamel, related to the fluoride exposure during the tooth. It can be very mild, and some of it can be quite severe. Risk factors with fluorosis: if you have water high in fluoride, formula again, if the child is ingesting a lot of toothpaste, and a combination. This is called a halo effect, if they're getting fluoride from a lot of different sources. Management of the fluorosis: microabrasion, where you may want to just take a little bit of diluted bleach and rub over the tooth with pumice, and then use a topical fluoride to remineralize that. Restorative, you can do a composite, or if it's really severe enough, you may need to go into veneers, crowns, or after the full eruption of the tooth. This would be a milder form of fluorosis on the left. This is when it's getting fairly severe, where the tooth becomes kind of chalky and pitted. Another way to avoid getting fluorosis is to not use so much toothpaste. You don't need a whole glob of toothpaste on the toothbrush. You only need a pea-sized amount. So, in summary, we've seen that oral health affects the general health. Untreated caries can lead to serious infection. So it's very important that we get the children in and get the caries treated. Children from the lower socioeconomic status generally are at more risk of getting caries versus those that are at higher socioeconomic status. We need to educate parents about the role that caries plays in diet. Breast milk itself is not cariogenic, but we do need to discontinue it at will when the first tooth erupts. Early childhood caries, how it is transferred from the caregiver to the child, is very important. Prevention is key. When they come in for their dental visits, we need to go over anticipatory guidance at the different stages, caries risk assessment, oral hygiene instructions. We want to get sealants on as soon as the child gets their 6-year molars, because sealants do reduce caries progression by 70%. Pros and cons of those sealant-based programs: fluoride is a really, really good remineralization agent. It helps arrest the caries, but if you get too much, you can get fluorosis. Do I have any questions? Okay, I do have one question here. What is the longest you have seen a parent breastfeed, and what impact did it have on the teeth? Okay, you know, it's surprising, but I've had a parent before that has said a 4-year-old, the 4-year-old was still breastfeeding, and I've had colleagues that have told me, one colleague told me in a 6-year-old, I believe, and the effect that it can have, again, it's mainly the frequency. So that frequency at that point, if the child that's 3 or 6 years old, that child is eating. And so by the time you combine the foods with that breast milk, that's when it becomes highly cariogenic. And so you see a lot of decay. So that would be the impact that it had on the teeth. The child had a lot of dental decay. Generally, the children that are breastfed for extended amounts of time are the ones that I see with one of the earlier slides I showed you, where you have just the nubs on the teeth. That's the impact that it has on the teeth. And we usually have to either take those children to the operating room, or we have to sedate them, and a lot of times they require extractions. Any other questions? Okay. Well, if there are no more questions, oh.
That, there was one other question I did see. Actually, I posed myself.
Oh yes.
Tell us what the impact of gold
grills,
teeth.
Yes.
You see some kids, the younger kids with the gold teeth on their mouth, kind of inspired by hip hop.
Basically, if they're actually
what impact does that have on the
from
teeth?
what I
guess they call them
understand, grills sometimes are not even being done by dentists. They're going to these little, houses or little warehouses, and I don't really know who's doing them, and they're just putting these plates basically sliding on top of the teeth. And when you're doing a crown on the tooth, there's a certain way that we prepare teeth. We have to go in, circle around the tooth, we take an impression, it's sent off to a lab, and then that crown is specifically made for that tooth. If someone goes to someone other than a dentist and gets something like this grill that's just slid on, number one, it's not particularly made for that tooth, so the gums can become affected. You can get gingivitis. You can start getting caries underneath because you have an opening or a pocket that starts forming between where that fake tooth is, that gold tooth, and the tooth surface. So lots of food and debris can start getting inside, and that could start giving caries underneath the teeth. So that really could damage the teeth as well as the gum structure. Yes. Okay. I do. Okay.
That means I get rid of my gold teeth.
What causes calculus?
Just jokes.
Okay, calculus is actually an accumulation of plaque when
see a couple other questions if you want to address them.
Hard or calcifies. That is actually calculus. So plaque is formed on the teeth back with the little the recipe that I gave. When you start getting you start eating different types of food, and you start mixing it with bacteria and everything, you get the plaque, the little layer that forms on the teeth from not brushing, and it sits there over a long period of time. It starts calcifying, and that is what's called calculus. Another question states, do you recommend fluoride treatments in the primary care setting? Yes, actually, and I really was kind of rushing this. Unfortunately, I didn't have a lot of time to go into a lot of what I wanted to go into with fluoride. I do have residents that rotate through my office from the pediatric department here at Morehouse, and one thing that we definitely like them to leave our rotation knowing is how to place fluoride varnishes, because sometimes they may see the child before we do. So that's why I definitely wanted to add that slide in about fluoride varnish, because it's fairly simple, but it's fluoride really is a good preventative measure. And if you're seeing the child before we do in a primary care setting, and you can assess by looking at the caries assessment risk of the child, the type of socioeconomic status. If the child is getting fluoride in the home or fluoride in the water, and you see caries already on the child's mouth, you may determine that this is one that could be a good fit for Flouride Varnish. So definitely I would recommend it in the primary care setting. Any other questions? Okay, well, I do thank you for joining me. I hope that it has been beneficial. I will leave my email address since I know I did rush some of the things at the end. It's kiddydoc, KIDDIEDOC02 at yahoo.com. If there are any other questions that anyone would like to ask me, I'd be happy to try to answer those for you. Again, I do thank you, and I hope that this was helpful.
This sounded like a very, very helpful presentation. I'm not a dentist, but this was very exciting for me. So I do want to thank you for your presentation, and I want to thank you for the insightful and engaging presentation you gave us. I would also be remiss if I didn't thank. Oh, I'm sorry, I interrupted you. Oh, I would also be remiss if I didn't thank the tech team led by Qualin and John behind the scenes, taking care of all of the technology and all of the gadgets to make us get this information out to you guys. As I said earlier, credits for this presentation were made possible through the CME program, which is well, I should say an application for continuing medical education has been filed. And the purpose for this webinar was
my purpose was to make sure that everyone knows that there is a link between oral health and general health.
Doc, can you tell us what the overall purpose for this webinar was? Great. Okay. So an evaluation for this webinar will pop up in another window if you're using Internet Explorer, and on another tab if you're using Firefox. We encourage you to check the resource section of the PrimaryCareForAll.org website for any additional information or useful resources associated with this webinar. We'd also like to invite you to the coffee shop discussions that we hold on Tuesdays. And also, next week we're going to have another free CE presentation entitled Primary Care of HIV Patients. Again, this series is made possible through a partnership with the National Center for Primary Care, the Association of Clinicians for the Underserved, the National Health Care for the Homeless Council, the Clinical Directors Network, and the Migrants Clinicians Network. This partnership allows PrimaryCareForAll.org to serve as a resource for the National Health Service Corps members and other clinicians working in underserved areas. Direct financial support for this webinar series is made possible through a cooperative agreement with the U.S. Department of Health and Human Services, the Health Resources and Services Administration, which is HRSA, and the Bureau of Clinicians Recruitment and Service Bureau.